I was a new medic, and I accidentally hurt a patient with the care that I was providing them. As a matter of fact, it's only pure luck that saved me from killing them or hurting them much worse. But I learned at least 3 main things from this, and I hope by sharing this story, I can help you learn those lessons as well. Me and a BLS fire department and my EMT partner all went on a respiratory patient. This is like a middle-aged woman with some kind of structural lung problem. Let's just call it like lung cancer or something like that. Something where the lung structure itself is a little bit weakened. So she was profoundly ill, and I intubated her. This is actually my first successful blind nasal intubation. That's, first of all, how long ago it was, but also how new I was. As an aside, everyone misses their first nasal intubation, at least their first one. So me getting this one is probably my second or third attempt on a patient trying to get this. In this case, I was successful. The same thing would have happened even if it was an RSI or any other kind of tube. The rest of the story just involves a tube successfully through her cords and into her lungs. Also working on an inline neb. An inline neb, for those of you that don't know, is a small volume nebulizer with whatever medication. I'm not even sure back then. This is so long ago. I think we didn't have ipratropium. I think cowboy medics gave atropine, actual atropine in a neb to kind of end up doing the same thing. But back then, she's working on an albuterol neb, but there's a tube out of her nose that I'm breathing through, right? So you hook an inline neb to this with the nebulizer that's nebulizing the albuterol, and there's accordion tubing that increases the volume of medication, and it hooks up both to the BVM and to the end of the endotracheal tube. In this case, however, the cap on the end of the L-shaped connection that hooks it into the endotracheal tube is missing. This cap can be popped in order to put a French suction down and deep suction an intubated person's lungs, but in this case, it wasn't there. So this is the inline neb that I was talking about. Has the T-piece that hooks to the neb, and over here this hooks to the endotracheal tube. This is the L-shaped piece that I was talking about, this white piece. And in the case I had, it had a soft gray rubber, but this piece here was missing. So the BLS firefighter is squeezing the bag and all of it's like whooshing out the wrong direction. Her lungs are tight and constricted, and so having this open air passage that doesn't lead to her lungs, all the air is going the wrong direction. So imagine it off like this. So each time I squeezed the bag and air went in, instead of going into the patient's tight lungs, it went out that. So how do I fix that? I fix this the way a paramedic does, with transport tape. Just went insane with transport tape to help seal that closed. Now it's closed. Now the air is going in her lungs. I can tell it's going in her lungs. And the firefighter even told me it's a lot harder to bag. Well, no kidding, it's harder to bag. Of course it's harder to bag because now the air is going into these tight lungs. As an aside, what the firefighter is talking about is actually compliance. What compliance is the amount of pressure it takes to deliver a certain volume out of the bag or the ventilator. In this case, what he's talking about is it's taking much more higher pressure, and you can actually feel that. It feels like there's higher pressure to push that volume of air that he's pushing with each kind. He's talking about compliance. So, of course, it's harder to push air in. Now you're going into tight lungs. That's what I want. It's not just like whooshing out into the atmosphere. And so we move on with transporter emergently. I think she's doing better. Whatever. We get to the hospital where it's discovered that I didn't recognize the tension pneumothorax. A tension pneumothorax that I probably gave to her. With her weakened lung, whether it's COPD where I ruptured a bleb, or where it's lung cancer where some weakened lung parenchyma burst or something like that, when that firefighter was actually squeezing air into her lungs that ruptured a lung. And actually she was in tension. She was hypotensive. That's a critically ill patient facing death. Not only is she hypoxic and hypercarbic and all of the other things associated with her primary respiratory problem, now she has an iatrogenic problem that is reducing preload, is causing obstructive shock, and is about to kill her. I did that. I didn't recognize it. Listen, mistakes happen. Not recognizing and correcting mistakes, that's a big problem. It's the first time it's happened to me. So I thought about not sharing this story for a couple of reasons. First of all is that it's profoundly and deeply embarrassing. It's difficult to examine one's errors. In addition, there's always this privacy concern and stuff like that. Like, I don't want to talk about my patients directly on this channel. But in this case, this happened more than 20 or 25 years ago. And I think that this is de-identified well enough for the patient not to be recognizable. And like I say, this is embarrassing, so I didn't want to do it. But because it's embarrassing is why I feel like I need to share this kind of story. Because all providers of all levels end up making mistakes like this. So I learned three big things. First of all is when someone says it's harder to bag, put the brakes on. I want to hear that screeching noise of the tires squealing, where everything else stops until I listen to lung sounds, where I feel the bag myself, where I feel the compliance myself, where I examine, am I giving this patient a tension pneumothorax? And the second lesson is related to that. The second lesson is that people don't learn the way that paramedic school always teaches. I am sure that I was told when compliance increases, when squeezing a bag gets harder, when more pressure is required, that's a sign of a pneumothorax. That's a sign of a problem. Go through your dope mnemonic and all that stuff. I'm sure I was told that. I'm sure that information got into my head. But until you're frightened, until you're embarrassed, until you have a strong emotion associated with this, associated with patient care, it doesn't stick the way that this sticks for me. From that point in my career, very early in my career, if someone says it's harder to bag or it feels weird to bag or has any kind of questions about the bag, it goes into my hand and they have my full attention until I figure out what's going on. So experiential learning is better than academic learning, than academic settings. And that's kind of what we try to do with our clinical rides and all of those things. But the trick is to figure out that level where you're allowing someone to make a mistake, where it scares them, where it embarrasses them, where it gives them a strong feeling, but it doesn't affect the patient. In this case, unfortunately, it probably affected the patient. She has a chest tube that she wouldn't have otherwise, she probably would have had that one way or the other. Would have been better if I'd have recognized it, you know what I mean? But in any case, the best learning comes from frightening or embarrassing a student, from a learner, even if they're not a student, without affecting patient care. So when I'm training, I try to allow my students that room to make a mistake, to learn from a mistake, but I can't allow that mistake to reach a patient. I can't allow that mistake to be anything but embarrassing. Does that make sense? And then the third lesson I learned from that call is that we all are a team and we all save each other. The firefighter attempted to save me. He may not have known that that's what he's doing by saying, hey, Bill, it's getting harder to bag. But that's what he was trying to do. He was giving me the hint with his knowledge that I was making a mistake. In the end, the ED is the team that saved me, right? That whole care team, starting in the pre-hospital setting with the BLS responders, followed by ALS responders, all the way into the hospital, and then through the hospital into pulmonology and respiratory therapy and all the rest of it. All of that team is working together collectively to find and recognize each other's mistakes, blind spots. We're trying to fill the holes in the Swiss cheese. I really only have 2 eyes, 2 hands, 2 ears, 1 mouth, 1 nose. Hopefully I'm not using my nose very much on a call. But by enlisting all those other team members and listening to them and taking the information that they're getting, what they're seeing, what they're feeling when they're squeezing a bag, by enlisting that, I end up making myself look better. It's embarrassing. We all make mistakes. We should all be able to talk about it. Let me know what you think. You know all the YouTube stuff, like, subscribe, share, follow, do whatever you got to do. Until next time, this is Angry Bill for Pre-Hospital Wisdom. Stay safe.